Oh, good topic.
All right, here's what we're going to talk about tonight, and that's sepsis. Um, sepsis has been the bailiwick or primarily talked about in patients admitted to the hospital either in the ICU or ER, and it has little been asked of paramedics to recognize sepsis, but that's changing. And the reason that's changing is we define sepsis and shock or septic shock is a very distinct and treatable entity that begins with your first encounter with the patient. So we'll go over all of these as we move forward. So first off, what is shock? I'm always amused when I watch TV and, some gal faints or something like that, and the doctor says she's in shock. Well, that's usually not true. Shock is defined as inadequate perfusion of the end organs in order to ensure function. There's not enough blood or oxygen to allow the vital organs to operate correctly. Symptoms of shock: loss of consciousness, hypotension, tachycardia, tachypnea, cool, clammy skin, decreased urine output, which may be difficult for you to visualize, poor capillary refill, and a narrow pulse pressure. Somebody who is 90 over 80 or 90 over 70 or something like that. That's a narrow pulse pressure. So we have to become familiar with ferreting out these symptoms and figuring exactly what's going on with our patient. A couple of things about sepsis, primarily seen in the elderly, and they usually exhibit signs of shock at a lower blood volume loss. They may be taking beta blockers and other drugs that mask the certain types of presentation for early shock. For example, if they're on a beta blocker, they may not become tachycardic, so we might miss it. And also keep in mind that younger or athletic patients have a delayed presentation with blood loss and shock. So a highly tuned athlete or a younger patient may not show signs of shock as early. Septic shock occurs when an infectious process in the body causes a cavalcade of responses that lead to a shock state and eventually multi-organ system failure. And the diagnosis and treatment of shock, septic shock, are aimed at restoring normal circulation and elimination of the offending cause. Here is a nice, fancy, over-the-top definition of the process of septic shock, which I don't expect you to memorize, but I want you to start with this. Here's a nidus of infection, whether it's an abscess, a pneumonia, a peritonitis, pyelonephritis, which be considered urosepsis maybe in an elderly patient who has a urinary tract infection, or maybe a patient who has cellulitis. And then the organism itself goes on to produce this cavalcade that we talked about. We'll go into this in a little bit of detail, but just know that all this fancy stuff that's going on are these toxins that are released by these organisms. And over time, all these things lead to the following: depression of the heart, depression of the vascular system, and depression of the organs, which will lead to shock and has one of two potential aspects or outcomes, either death or recovery. If you go into multi-system organ failure here, you're most likely going down this pathway towards death. What we need to do is recognize this back here. Here's what EMS has the ability to see. Not so much the organism, but the nidus of infection, and realize that their patient may be heading towards septic shock. And that's where the changes in protocols, I'll give you some changes in protocols that we've made in our organization, allows us to treat early on. So septic shock treatment consists of adequate ventilation and intubation if needed, IV fluid, diagnostics, which we'll talk a little bit about in the field, vasopressors we'll talk about, and antibiotics. Over 750,000 patients are diagnosed with sepsis annually, an increase of 90% in the number of diagnoses over the last 10 years. Is there more sepsis? Well, it's possible because there is a rise of drug-resistant bacteria, but we're also keen in on recognition. So I think it's a good thing that there's an increase in sepsis because we're realizing early on that somebody might be heading that way, but we're also dealing with this idea of drug-resistant bacteria. For the emergency physician, that's somebody like myself saying, I'm sorry, you've got a cold, or you have a sinus infection that's probably related to a virus. You don't need antibiotics. And it's very, very difficult as a provider. It sometimes takes twice as much time to tell a patient they don't need antibiotics than it is to just write a prescription and get them out of the ER. In otherwise healthy individual, sepsis has only about a 5% mortality. If severe sepsis develops, that rises quickly. And if septic shock occurs, where hypotension is the hallmark for that system and entity, you can have mortality up to 50%. Who's at risk for sepsis? Well, elderly, infants, surgical patients, and the chronically ill. That's your frequent flyers, so to speak. You're elderly, you're demented, you're chronically ill, immunosuppressed patients, people who are on chemotherapy, for example, are all at increased risk of contracting sepsis because they have a compromised immune system and they're not able to fight infection as rapidly. Mortality rates are also raised. So let's talk a little bit about definitions. These are when we start to get into definitions that are bordering on need to know for physicians and higher providers. However, you should be aware of them as a paramedic and EMT because you're going to be the first person to encounter it. SIRS is a system called Systemic Inflammatory Response Syndrome, and it's part of sepsis. It's kind of like one of those old Chinese menus where you can say 1 from column A, 2 from column B. So sepsis is a suspected infection, whether it's an elderly patient with a cough or an elderly patient with a fever, and they say, oh, grandma doesn't act right, and she's got a smelly urine or something like that. So you suspect infection, and any two of these criteria, that we see here. Temperature greater than 100.9 or 38.3 or less than 96.8. This is important to remember that sepsis can increase the temperature or decrease it. Heart rate of greater than 90. That's not a very high trigger. So very often we have to look at this and go, and use our clinical acumen to say, this person looks sick, they're acting sick, they might be a septic patient. Increased respiratory rate, an altered mental status, so GCS less than 15. And I should say that's a new change. Somebody who has dementia, for example, and they're in a nursing home, or a care facility because of dementia, and they have an altered mental status. That's not a new change. A blood pressure less than 90 or a mean arterial pressure of less than 70 or greater than 40 over baseline. White blood cell count, you're not going to get this in the ambulance unless you're a very sophisticated ambulance. But a white count greater than 12 or a blood sugar in a non-diabetic greater than 140. So let's put this together. Severe sepsis is sepsis, which we defined here as suspected infection and any two of the above. Severe sepsis is where things get a little bit worse, where your blood pressure drops, your PaO2 goes down, you don't produce as much urine despite fluid resuscitation. Increase in creatinine is something you have to measure in the lab. Increase in INR is something you need to measure in the lab, but these are things that happen when somebody might be on Coumadin. Ileus, platelets less than 1,000, hyperbilirubinemia, and lactate. For the paramedic, most of these things you're not going to be able to check. Blood pressure, you obviously will, and we'll talk about this lactate here in a couple of minutes because a lot of agencies are going to what we call a point of care lactate, which sends them down the sepsis pathway. Septic shock is severe sepsis plus blood pressure of less than 90 and a lactate greater than 4. So I'm going to quickly go backwards, and you'll see that we've got a continuum. We've got SIRS, which is these signs and symptoms here. Then we declare sepsis. Then we declare severe sepsis. And then we declare septic shock. So it's a continuum. You might see a patient way back here, or you might see a patient here, anywhere along the continuum. Intervention is the most important thing. So this is a very famous study that hospitals have been having to follow for the last several years, surviving sepsis campaign bundles. And what they are targeted to do is respond quickly, measure a lactate level, get blood cultures going, administer antibiotics, and a 30 mil per kg crystalloid challenge as quickly as possible. And this is supposed to be done within 3 hours. Part of that 3 hours is handing over to EMS the ability to recognize sepsis. We'll talk about this a little bit when we talk about controversy about measuring lactate and broad spectrum antibiotics. This is easy to do for a paramedic, to give a fluid bolus. You guys usually get that done pretty easily. But there are some agencies now where they have a point of care test, just like you can check somebody's blood sugar. You can check a lactate level, even carrying broad spectrum antibiotics. Within 6 hours, if people don't respond to the crystalloid challenge, you should be starting vasopressors. We'll talk about those. Measuring arterial blood pressures, which is something you have to do in the ICU, and remeasure the lactate if it was initially elevated. We do that in the ER all the time. So, signs and symptoms of sepsis can be something simple: chills, low-grade fever, nausea, vomiting, and other flu-like symptoms. Occasionally, acute mental status changes like confusion, lethargy, or increased fatigue. Here's an example of purpuric rash in a child with meningitis. And this is the meningeal infection rash we might see in children. What about influenza? People say they have the flu. We don't want to, call out the army if somebody just has the flu. But sepsis can be misdiagnosed as the flu because the symptoms are nearly identical early on. You try to rule out sepsis when considering the diagnosis of influenza. What are the sources of infection? Just like we had in that big, large as we had in that very first slide where we have a source of infection, it could be dirty wounds, complex wounds, burns, puncture wounds, impaled object. Somebody gets steps on a nail if they are diabetic and they don't know it, or they have been stabbed, for example, and it passes through the intestines, or crush injuries. Infected wounds, for example, in children or diabetics, or maybe IV drug abusers, for example. And then progression of sepsis, where the local infection now begins to spread. Once that happens, you get vasodilation, which is the vessels in the blood system get larger. And as they get larger, your blood pressure goes down. That will lead to an increased local blood vessel permeability, and phagocytes will rush to the area. And think of this as that cascade that we showed you early on. This is what's happening in the progression of sepsis. So here is a visual clue. You've got some kind of toxic stimuli. Your blood vessels start to release these mediators in the body. All these mediators here lead to capillary leak, either in the vessels or in the lungs and the heart, and eventually you can lead to hemorrhage. So this is a visual aspect of what goes on at the cellular level. Septic shock can be, again, rapid breathing from burns. Somebody might have peritonitis. They show this as a female patient, and she might have what's called as a septic abortion, meaning that she's lost, had a miscarriage, and the retained products in the uterus can cause an infection. That can lead to peritonitis. If a catheter is pregnant with an elderly patient, they might have a urinary tract infection. Usually the symptoms would be a warm, bounding pulse and deep, rapid breathing and fever. So we talked about SIRS, the local inflammatory response eventually becomes ineffective and infection begins to spread beyond the original location. That is the definition of sepsis, because you now move into the bloodstream. So something that was a simple pneumonia, although pneumonia is never simple, but let's say you have a pneumonia, a small pneumonia, and it gets worse, and now it spreads into the bloodstream, and that local inflammatory response becomes part of the sepsis pathway. The body initiates the inflammatory response, and infection and sepsis begin. Severe sepsis will lead to organ dysfunction characterized by low blood pressure, altered mental state, hyperglycemia without a history of diabetes, meaning the blood sugar goes up even if you don't have diabetes, hypoxemia, decreased urine output, and the body's response to severe sepsis is to release all these things: histamines, prostaglandins, cytokinins, all these things that we talked about in this slide will wind up causing a low blood pressure as a chance to kill the bacteria. What's happening here is the body is using whatever it can to make the environment as toxic as possible to whatever this offending agent is, whether it's a bacteria or a virus. And eventually it makes itself a problem. So when aggressive fluid replacement and vasopressors fail to maintain a blood pressure of at least 90 with continued signs of severe sepsis, the patient is now in septic shock, and that's when we get to that 50% mortality. Multiple organs begin to shut down, 2 or more organs fail to function, and we get this MODS syndrome. And that's a MODS syndrome is where we're at the end of the rope and we can't get that patient back. Final stage of infection that has overtaken the body, and then death shortly follows. Multiple organ dysfunction syndrome in sepsis, that's MODS. What do we do? What can paramedics do? Oxygen as much as possible early on. Ventilatory support, you're going to do that anyway. If somebody needs to be intubated, we can intubate them. End-tidal CO2, we need to keep an accurate record of capnography and pulse oximetry. Remember, pulse oximetry is only about 5-minute-old information, but capnography is every 6 seconds. So if we have somebody who's got an end-tidal CO2 that's going down or rising, we can keep an idea of how our response to treating the patient is. And I'll talk about that in a few minutes. We want to monitor the blood pressure. All right, you want to take frequent vital signs. Initiate an IV. All right, you're going to do that with crystalloid bolus of 500 ml increments until you get the blood pressure to at least 90. Consider vasopressors. A lot of agencies carry dopamine. People who are not responsive to fluid boluses. And then once you successfully locate infection, considering IV antibiotics. In the emergency department, if we suspect sepsis, we start full bore and do all these things. A, B, C, D, E. Oxygen, intubate, start antibiotics early, get our blood pressure online, and get the blood pressure up and elevated as much as possible. And we start antibiotics early. So, reminder is that septic patients are prone to a rapid deterioration. They can quickly fall off a cliff. So advanced life support providers should be utilized if available. And that's why we've put into our protocols early recognition of sepsis and therefore early treatment. How do we identify where the potential sepsis is? And that's by our symptoms. If we have an altered level of consciousness, confusion, we might consider that the brain or the central nervous system is infected. We look for tachycardia. We look for decreased urine output and a slowly creeping creatinine. In the blood system, we're going to look for things like platelets going down. The liver is going to be indicated when we have an increase in liver enzymes and decrease in the change in the clotting factors in the blood. And the lungs will show us that they might be a potential source by rapid breathing and decreasing oxygen saturations. Now keep in mind that an infection down here in the pelvis can cause all these signs and symptoms and might not necessarily point to an infection in the brain. So we have to use our clinical judgment to see where we might be going. Sometimes we shotgun it and put people on antibiotics hoping that we've caught it somewhere. So we talked about the continuum, and this is the continuum outlined on a piece of paper. We start with SIRS, that's the inflammatory response, and these are the things that we look for. This you can figure out in the ambulance, this you can figure out in the ambulance, and so can this. Sepsis is at least 2 SIRS criteria, plus a known or suspected infection. Severe sepsis happens when you start to get acute organ dysfunction. Septic shock happens when you have refractory blood pressure problems despite your treatment. And MODS, we talked about, is organ dysfunction in acute illness. MODS, remember, we talked about multi-organ dysfunction. So EMS and sepsis. Where does EMS come into play? And this is where we've changed some of our pre-hospital emergency care. EMS and sepsis, it's more likely encountered and more often suspected if you look at your patient population. They did a study over 9 years in Seattle, and they reviewed close to 500,000 runs, 407,000 runs. Here's what they found. Severe sepsis was 3.3 patients per 100 encounters, as opposed to a heart attack or an AMI, which we talked about last month, which was only 2.3 per 100, and then stroke was 2.2 per 100. So we spend all this time in paramedic land worrying about these things when sepsis has a higher number than any one of them. So severe sepsis was 3.3 per 100. 40% of all sepsis admissions arrive by ambulance. So nearly half of all the sepsis patients come by ambulance. EMS contact time is generally about 45 minutes before they even get to the emergency room. So you guys are in charge of the patient for the first near hour. And we talk about trauma and the golden hour. Well, sepsis is also the golden hour. And you've taken up 45 minutes of that. So what do? What can you do to help us out? And recognition is the most important thing. Here's a trend of sepsis. And you can see over the years, one of two things, we talked about this in an earlier slide. Either sepsis is getting worse with resistant bacteria, or now, more than likely, contributing to this is the recognition of sepsis. And this is where you guys can make the change. Look how high the delta is for the slope of this change. Between 2007 and 2009, the slope is sharpest there. Here's heart attacks and strokes, pretty much unchanged, 2.2 or so per 100, whereas sepsis is going up higher and higher. In New York State, they began by actually putting out a protocol for a suspected sepsis, and they put it on 3 levels: EMTs, advanced, and paramedics. EMTs, ABCs, airway management, obtain blood glucose if equipped, and then there's your stop point. That's about all they can do. Advanced, you can start an IV and start with a 500 milligram or a 500 milliliter bolus. Notify destination hospital of potential sepsis. This is the most important thing that paramedics can do. In our protocols, we have said this is a potential sepsis patient, which allows the ER to get things ready early on, just like you would report a stroke one or heart one. For paramedics, EKG, normal saline to a total of 2 liters, And in this area, we're considering antibiotics and measuring of lactate. We'll talk about that in a few minutes. Physician, we can give more saline, and then norepinephrine is beginning to get that blood pressure up. Norepinephrine is the first choice for treating sepsis. You guys usually don't carry that. If you have any vasopressor, it's usually dopamine, and that's okay to start dopamine, and then we can change it to norepinephrine in the ER. Here's the key. Focus on rapid identification, IV hydration, and early notification as a concern for potential sepsis. We're used to codes in the hospital. So you'll hear a trauma code in the ER. You'll hear a code 99. Now, in a lot of facilities, they have something called a code sepsis, or they might call it a code blood, or something to that effect. And code sepsis is when they're working just as diligently to get these key considerations going on as a patient hits the door. So we talked about capnography. What is end-tidal CO2? There's a couple of different things. Number one is ventilation, how a patient's breathing. Number two is perfusion, how is the heart getting in, the blue turning to red. And lastly is metabolism, how are we metabolizing the glucose in our body and the oxygen in our body, and how do we get that going? Capnography, or end-tidal CO2, lets us know quite a few things. We have an accurate respiratory rate. So remember, one of our criteria is having a respiratory rate greater than 20. Airway patency, like bronchospasm and obstruction, we can recognize that. That's another lecture for another day. Shock states and response to treatment. We can see if somebody's getting better. So how does perfusion, remember we talked about pH, and sepsis is usually a state where the body is acidotic. So capnography reflects perfusion. So if you have a decreased cardiac output, you'll have a decreased end-tidal CO2. CO2 is transported in the blood as bicarbonate, and that's what we're essentially measuring when we measure end-tidal CO2. End-tidal CO2 reflects lactate, so that's a good reflector of sepsis. There is an inverse relationship with these two, so as end-tidal CO2 goes down, lactic acid is usually increasing, and that's the two things that we can measure pretty quickly in the ER. In some institutions, this is kind of an older type of time limit, but lactate requires about 172 minutes, whereas point of care, meaning you just finger prick somebody and put it into the machine, about 21 minutes. There are some agencies in EMS that are carrying these little machines that'll let you know what a lactate level is right away. So you've got somebody with abnormal vital signs, you suspect they have sepsis, you do a lactate level, you can report to the ER that I've got a patient with a fever, tachycardia, hypotension, a lactate level of 4, and I suspect sepsis. Get ready, we're coming in. Some medical directors have even given their, in this situation, the ability to start antibiotics in the rig. So here's an example of shock and a protocol we have for shock in our agency. Hypovolemic shock, there's 3 types of this: cardiogenic shock, hypovolemic shock, and then distributive shock, which is sepsis. And down here, we'll give fluid boluses, can repeat up to 1,000 milliliters, and if it persists, we can give dopamine. Here's dopamine itself, or intropin. It has both alpha and beta receptor actions, and essentially you can titrate. Primary indication is cardiogenic shock, but it may also be helpful in septic shock. Norepinephrine is the most often used in the hospital. So if you start dopamine to get a blood pressure up, we can change it to norepi. There are contraindications and side effects, and they can happen, and they'll be in your protocol. All right. What I'll do then is I will take questions.
Looks like James DeJanin asks, if capillary leakage is due to permeability changes, will a fluid challenge not exacerbate the issue?
That's a very good question. And so the question is, if you've got permeability and leaking, if you give fluid, are you going to make things worse? And the answer is a definite maybe. You've got to have blood pressure to get perfusion. You have to have blood pressure to get everything going. So the best thing to do then is to give the fluids. You might make things worse. Just like if you have somebody in congestive heart failure and give them too many fluids, you can drown them. Or if you've got a rapid response and figuring out that this is sepsis and you begin antibiotics early, you might get things going in the right direction. So yeah, if you've got fluid leak, there is definitely the potential that you can make it worse. But it's a balance, it's a scale, it's a risk.
Okay, wait a minute. H extend, what do you mean, James? You can unmute your microphone if that's easier, James.
Yeah, sorry. No, I was just talking about a plasma expander as opposed to just normal saline. Would that be a better short-term fix?
Say that one more time.
Yeah, I was just wondering if like something like a Hextend, like a plasma expander would be better than just normal saline in the short term.
Yeah, so the question is whether or not something like Hextend, something that helps with capillary leak syndrome might be better. And that's something that I would leave to the ICU physician and the intensivist who's taking care of the patient. Plasma expanders are kind of difficult. Sometimes it's like a puppy chasing their tail. I try to avoid them unless I've got a direct consultation from a pulmonologist who says, yeah, give this, it's our last ditch effort, or I would start this right away. So really fluids are our best challenge, getting antibiotics on board early and getting that blood pressure in a range greater than 90 with vasopressors is probably our best dose or best treatment.
Awesome. Anybody else out there got some questions? We got a little time here. You can pick Dr. Eschelbach's brain while he's here. All you have to do is click to unmute your microphone if you'd rather talk rather than type. Well, so far there's crickets.
Okay, so I'll talk a little bit about, in a few remaining minutes, let's talk a little bit about controversies and protocols. Number one is recognition. We talked about that until we're blue in the face today, right? We want to make sure that we recognize it. Starting fluids and starting pressors are protocol dependent. What are the two other things that we've talked about that some medical directors say, no, I don't want that to happen yet, or I don't know if that's helpful? One is measuring serum lactate levels. There are machines available, like I said, where you can do a finger prick or get a blood sample from the venous aspect of a patient and draw a quick blood sample and check and see if the lactate level is increased. It does have some controversy because what are you going to do with that information? What does that information lead to? And now you have an abnormal blood test, but you can't do anything. So some agencies are beginning to say, okay, I want you to carry a gram of Rocephin and start a gram of antibiotics before they hit the hospital. Now on a 45-minute transport, it might make a difference between life and death. It might also increase antibiotic resistance where somebody else has got a low blood pressure because they're in cardiogenic shock and antibiotics won't do anything. Or they might have a different type of shock, like anaphylactic shock, and the patient really needs epinephrine or something like that. So those are the controversies when it comes to it. There are some medical directors who say, look, they're not going to hurt anything by giving them, at least we know that the patient has an elevated lactic acid. We suspect sepsis, so let's get antibiotics on board early. So those are all things that are possible. All right, any other questions? Going once, going twice.
I've got one more. I don't mean to keep beating on the issue of the leakage, but is at least in the ER, is there a role for Lasix when you're trying to basically balance the fluid challenges with the extracellular sort of inflammation, if you will?
All right, so the answer is there a role for Lasix when you're treating these people with capillary leak syndrome, et cetera? And the answer is no, not really. Lasix is, a diuretic. It works through the kidneys, and most of the time, these people have hypotension, low blood pressures, and their kidneys aren't functioning as well as they should to begin with. So giving Lasix is not really the answer. We've even taken Lasix out of some of our protocols for congestive heart failure, for example, because it takes at least an hour for it to start working. So when you get into something called ARDS, acute respiratory distress syndrome, you have to try and stay exactly 2 liters above the patient as far as their ahead of the patient as far as their capillary leak syndrome. So that type of treatment with fluids is something that requires intensive care and requires that the physician treating the patient has an arterial line in so they can read the difference between the right heart pressure and the left heart pressure and the pulmonary capillary wedge pressure. All these things are very, very sophisticated and beyond the EMS realm, really. It's even beyond, my realm sometimes because I don't do it as frequently as the intensivists can do.
Anything else, guys and gals? Oh, I got James saying thank you. All right, how about my EMTs? Richard, did you get anything out of this? You also have to still be there. Richard. How about you, Devin? Oh, Richard, yeah, sure did. I'm absorbing a lot. How about you, Devin? You're in P1. Did you get anything out of coming tonight, even though you don't get a technical credit for it? She said she learned quite a bit.
Okay.
So now we got Ashley, James, and Brian. Haven't heard anything from you tonight. Are you still there? Ashley, I like hearing the doctor's aspect.
Okay. Yes, ma'am. Okay.
Brian? Yep, he's there. And James, we know you're there because you've been asking questions. Anybody got anything else you want to ask Dr. Eschelbach before we close this up? We're a little early tonight, so you got a chance.
Jane, I got a question. This is Priscilla.
Hi, Priscilla. I did miss you, didn't I?
That's okay. One thing that I've been trying to figure out is how we measure some of the measurements that
Hey, Priscilla,
obviously the vital signs and mean arterial pressure and
Priscilla, your bandwidth is really, really low, so it's cutting in and out. Can you briefly type your question, kind of a summary of it, because it's cutting in and out so much we're not understanding you. We'll give you a minute. We'll be patient. In the meantime, Brian says, learning the different criteria helps a lot with differentials and treatment decisions. Yes, it does. And sepsis is one of those situations that can get ugly so fast. If you miss the boat at the beginning, you can end up with a mess on your hands.
Yeah.
All right. Ashley, always remember to treat your patient, not always the machine. That's true.
Right.
Treat the patient, not the monitor. I'm sure it sounded like Priscilla's question was pretty full, so we'll have to give her a minute to try to figure out how to type that.
I'll talk a little bit about vital signs. If somebody has a blood pressure less than 90, here it is. How is it possible to measure some of the more advanced vital signs, like stroke volume, when measuring cardiac output? Oh boy.
I'm glad you got
Good
that
question. Well, one of the things that we do rapidly in the emergency department is stick an ultrasound on the patient, and actually we can do a mini volume status by looking at the inferior vena cava as the heart compresses on ultrasound. It's known as an echocardiogram. We can get a rough and dirty idea of the heart and whether or not the inferior vena cava is collapsing or if it's full. So if we've got low cardiac output, low vital signs, and low blood pressure, we stick an ultrasound on the chest of the patient, and we can do a quick guess as to what's going on with the patient. What is the minimum MAP to maintain cerebral perfusion? It's between 70 and 90. Devon is asking. The minimal MAP to maintain cerebral perfusion is between 70 and 90. Less than 70, we start to have decreased cerebral perfusion, and we want to get that up as high as possible. That's why a systemic blood pressure less than 90 is a good indicator that we're heading towards a systemic sepsis syndrome.
Great questions. Did you get your answers you were looking for, ladies? Okay.
All right.
The infant in your slide with the big sore, what was that?
Oh, that was a pressure sore from a child that had been neglected and left to lay there too long, and they wound up with a pressure.
Oh, sorry, Devin. My mistake, but hey. Oops. Okay, open mouth, insert foot, chew vigorously. Okay.
All right.
All right. And it looks like things are slowing down. I guess this one will take me a little bit longer to get posted, guys. I have to wait until I get back settled in. I've had computer issues again, and I have to get the new program out so I can edit. But it should be up on the website probably within the week.
All right. Very good.
Thank you, Dr. Eschelbach, for your time tonight.
Good night, and thank you.
All right. Good night. Be safe. Good night, all.